right. Well, it is 12:35. It's time for us to start. This is the Clinical Consultation Network. Welcome, everybody. We've got some great guests today. We've got our start team on here. Michelle Bagby, Krishana Overstreet. I don't know if Carrie's going to contribute as well. She's on camera here, but in any case, I'm very anxious to have them talk about the START program and everything that's been accomplished since the last time they were on. So we'll get to that in just a moment. But first, let's make a few announcements. This is, as I was talking about, we have mental health crises from a biopsychosocial lens, the trifecta of factors we need to understand, biopsychosocial. We'll get to that in a moment. May 23rd, our fourth Tuesday feature with Dr. Brandy Kelly is going to be happening. And so I hope you'll join us for that one. That's should be a great presentation. May 30th, we've got Tennessee Association of Mental Health Organizations and Volunteer Behavioral Health here to talk to us about 988, the new suicide hotline. On June 6th, we've got Voice It, the voice translator for people who have articulation difficulties. This is a great tool, and we're going to have them here to talk to us about some of the more recent results from their product. We don't have anybody yet for June 13th, but I know Babs is searching and turning over the stones to find somebody for that day. And then June 20th, we've got, what's TCCY? Tennessee Council on Children and Youth?
Tennessee Commission on Children and Youth.
Close. Kids Central. They're going to be here to talk to us about Kids Central, which I assume is one of their programs. So we got a great lineup upcoming. And now it's time for today's Get Smarticle, if we have one. Do we have one?
Yes, we have a guest.
Okay. It's not, but I'm not supposed to do it. Okay, good.
I'm going to go ahead and share my screen. So see if I can get this done.
This is Krishana. Krishana is going to do the Smarticle.
Yes.
All right. Very good. And okay, now this isn't going to be your last thing to do on here, is it?
Yes, it's going to be my last thing to do.
You have to introduce yourself and give us your interesting fact.
I thought that was just for presenter people.
Well, we're going to make it for you as well, especially since we discovered that you had some interesting facts.
Oh, okay. Do I do that before I share? How does that work? What do I do?
Go ahead and just introduce yourself real quick and tell us if you have your interesting fact.
So my name is Krishana Overstreet. I am the team lead for our START program in West Tennessee. Hello out there to my START team members. My interesting fact, which is what I just shared with them, is that I am a big old nerd. When I was growing up in South Mississippi, hi Taylor, I was part of a debate team, and we did this thing called Mississippi Youth Congress, where we pretended to be members of Congress. We elected ourselves to the Senate and the House. We elected House representatives. We made up bills. We debated those bills on the floor, had them passed. We were in full-fledged suits in Mississippi heat during the summer, and we loved every moment of it. We passionately debated the Constitution, and and I think only one of us of my little cohort ended up going into law. Yeah.
Okay.
Most of them are teachers.
I was wondering if anybody went into politics. It would be great if we could get your pool of people there into politics.
I think two of them actually ended up running for positions in Mississippi. One is like a professor at law. One of them actually is a criminal lawyer. But yeah, not that many people know the Constitution by heart. English history is my thing, and we used to be so dorky.
So proud to have you as part of our team based on that interesting fact. I just must tell you.
Okay, I'm going to go ahead and get started. Okay.
Yeah, go ahead.
Okay. So this Get Smarticle is, I'm going to go ahead, I'm going to try to cycle through. Y'all see that okay? Let me move my thing. There we go. Okay. So the Get Smarticle I'm presenting is actually called Prescribing Antipsychotic Medication for Adults with Intellectual Disabilities the shared responsibility between mental health services and primary care. This was published in July 26th of 2021. I'm going to butcher their names, so I'm not going to go over them, but you have that information there. I'm actually really, really excited about this article because I picked it before I knew Michelle's topic, and it really aligns almost perfectly. So look at that. The 10 Start people are always in sync with each other, even when we don't try to be. Okay, so this study is actually based out of the UK, but I thought it was really kind of fascinating because it has kind of like a twofold purpose. The purpose was an analysis or review of the data gathered from an audit by the Prescribing Observatory for Mental Health, focused on a quality assessment of antipsychotic medications of adults with IDD, and basically kind of review of the mental health services they were receiving. This is actually the fourth audit of this kind, and so it's kind of the big picture was going through how they're getting these services, how they're being prescribed medications, and the quality in which the care they're being received. It's also a review of the benefits and the clinical presentation for any antipsychotic medication, and is there a continuous review of the side effects of these medications, especially with the ID population. The majority of individuals who receive documented review of addressing the benefits of antipsychotic medication. However, the monitoring of those medication side effects were limited, and it kind of varied across the level of services they received. So that kind of depended on what service they were receiving and kind of how it worked. Okay. And if I go too fast, like stop me. But I have 5 minutes. Carrie told me I had 5 minutes. So I'm going to make it quick. So the study is one of the largest of its kind, and that's really what kind of got me drawn to this one. Was it was 977 individuals. I know if you guys are not aware of it, the IDD population is probably one of the most under-researched populations. So I was really kind of excited there was this many individuals that were available for the research. It did so there were 46 healthcare organizations that submitted data, but all 64 of them participate in what they call a quality review. So there was going to be anything from this research study and a couple of other ones. All 64 organizations across the UK were invited to participate and kind of make changes to their program based on the research study. So of that 977, we had 623 males, 354 females. A large majority of them identified as white and British. And then the largest section, the next section was mixed individuals. The median age was 44.9, but most of them were actually in the 26 to 35 range. The level of disability, which I was really kind of excited about, is that we have a kind of a cross section of all of those scales. There's borderline or mild, moderate, severe, and profound. And the good part about it is that those categories actually translate from the US to the UK as well. So even though it's a UK study, the demographics are pretty much the same. The psychological disorders, the largest demographic were those developmental disorders. Those are going to be things from our, developmental disorders of speech and language, scholastic skills disorder, and those pervasive developmental disorders like Rett, autism, and those kind of things. At least a little more than half of the individuals did have an additional diagnosis. And what I really thought was interesting in the study was it was doing, so for this population IDD, sometimes individuals are prescribed medications, antipsychotic medications to kind of address their challenging behaviors, and they may not have an actual psychiatric diagnosis other than IDD. And so a large majority of these individuals in the study did have an additional diagnosis, and only, I want to say 103 of them or 113 of them actually only had ID only. So that was really interesting. And let's see. So the aspects of the study that they reviewed were the monitoring of the treatment results of the primary care clinicians and the mental health services, like their role responsibilities. So the assessment was, if the individual is receiving antipsychotic medication management through their primary care doctor or a primary care clinician, what is going on with that communication? Is it something that a lack of role responsibility is the result of not knowing who is supposed to do what, or are we not reviewing the side effects for a variety of reasons? That's the main part of it. It's like, hey, what's going on here? Why is this review not happening? What can we figure out what's going on? The other part was about clinical quality, which I thought was really interesting. Is there a difference in the clinical communication between primary care doctors and the mental health service providers? What is the nature of that communication? Are they kind of modeling the fidelity of kind of what is needed when we're reviewing medications and prescribing medications, and that kind of thing? So I just was very excited about my word art, so I want you guys to just bask in the glory of those two hands. That's it. I found a word art tool and I did that because, that's part of it. So just look at that. And it matches my background, so enjoy that. There we go. Okay. So the basis of this study was actually, so one of the things they really wanted to assess is that our clinicians and are the individuals that are receiving services that are part of the IDD community, are they receiving those best practice recommendations? The best practice recommendations that this study really focused on were those that were coming from NICE. And NICE stands for the National Institute for Health and Care Excellence. It's kind of like a governing board that makes recommendations for in the UK for how do we work with individuals with ID over there. So they have a set of guidelines that they really kind of recommend for how individuals, how their care should be operated. It's fairly extensive. So this particular study only dealt with what they call guidelines 12 and 18. And it largely deals with the fact that adults with IDD should have a complete physical health review, the antipsychotic medication to manage their behaviors with an only if approach. And that means that we have exhausted all the other options. We know exactly what behavior it's supposed to target. There's a consistent review of it, kind of that holistic approach, which is very much in line with our own START model. So like, even though I didn't try to, it really kind of goes through and addresses those issues, documentation for the rationale of the medication. And what's really, really interesting is that one of the assessment protocols that NICE actually recommends as part of our START manual tool, which is called the ABC, which is the Aberrant Behavior Checklist. That's actually one of the tools that the NICE organization recommends for individuals to utilize to assess the efficacy and the kind of how the medication or the antipsychotic medication is actually addressing those problem or challenging behaviors. One of the other recommendations that they make is a consistent review. So there's a full multidisciplinary team review at 3 months, and then every 6 months there should be an analysis and review within the kind of their care team about the efficacy of this medication. Can we reduce or eliminate it? Is it achieving the goals that we set out to achieve? And what can be done to kind of supplement the medication or kind of have an alternative intervention. There's also clear guidance of responsibilities and the monitoring of those medications and how it should be transferred between disciplines and services. So now the conclusion. It wasn't really shocking necessarily to me that this kind of happened, but they say that under primary care physicians and clinicians, the monitoring review of antipsychotic medications may fall short of recommended best practices. And I just realized I had a typo. So what was kind of discovered from this research was that if the new clinician, the primary care doctor, did not have a full detailed explanation for kind of what was expected of them and who was responsible for what, they didn't have that consistent monitoring that the NICE organization kind of recommends. So it showed that there was a failure on the mental health service providers for kind of explaining what the responsibilities were and kind of dictating to the clinicians about what's expected. There was kind of recommendations that came from it that really focused on, they were prescribed medication. There wasn't an overprescribing of medication. They kind of monitored things that they were medically supposed to monitor. But when we looked at the analysis of whether or not they were tracking those side effects and doing that consistent review every 6 months, that was not happening. Okay, so the START member in me always likes to focus on not necessarily what is wrong, but what is strong. So now that we've identified this problem, what can we do to fix it? So communication issues across services and systems is not new to the IDD population. It's not new apparently across the globe. So how do we kind of really address these issues regarding medications? One of their suggestions is like the shared care agreements already exist for the treatment of schizophrenia. It seems to be a really kind of a big thing with a clear outline of responsibilities, who's supposed to monitor those things, and all that other stuff. We can kind of create, or the suggestions was this can be created for the same lines as with the ID population regarding all antipsychotic medications. It should be individualized and clearly communicated about the treatment plans. And one of the things that I like to do I thought about this when I read this, was that we call it a DSP for PCPs, which basically they need a formalized letter that tells them who the responsible party is, what the role responsibility is, how often they should be doing this. And when given this guideline, all the clinicians were able to kind of monitor those medications, monitor and track the side effects. There was kind of really no issue once they were given clear guidance on how to proceed, which I thought was really, really kind of fun and interesting that we kind of have all these kind of plans and documents in line for our population, but it also works for clinicians too. So I thought that was really interesting. And yeah, that's the end. And did I meet my time frame? Yes, look at that. I'm proud. There we go.
Outstanding, outstanding. Yeah, thank you for sharing that, Krishana. That's a really great article. It underscores a really key issue I know we face out there every day through START. And so thank you so much for sharing that. And with that, I suppose we'll transfer over now to our feature presentation with Ms. Michelle Bagby, who is the director of this 10 START program. And she is going to share with us some outcomes and some information from START. So, Michelle, welcome to the Clinical Consultation Network.
Hello, I'm back. I've been here before. I'm Michelle Bagby. I am the Director of Behavioral Health and Crisis Services for DIDD here in Tennessee, and the statewide clinical director for 10 START, as Bruce indicated. I struggle with interesting facts. I feel like I've been on this thing a few times and I never remember which ones I've used. So I came up with a mildly interesting fact about, I will say, I have very polarized interests when it comes to music and entertainment. So I have noticed, and if you've ever been in the car with me, you know, I'm a big fan of hard rock and heavy metal. And I also like musicals. So it's a very broad spectrum of happy and hard music. And that's pretty consistent across other genres of entertainment too. Same thing with TV. Love horror movies, intense action movies. But I also have to buffer at the end of the day before I go to bed with happy shows like Ted Lasso and Shrinking, which I highly recommend if you haven't watched them yet. So that's the closest I got to an interesting fact, was just how polarizing my interests in entertainment are.
How many times have you seen Korn in concert?
Over 36 at this point.
My Lord, that's an interesting fact in and of itself.
Yeah, and that's where I got engaged also, and how I met my husband. So obviously metal is in my heart for a lot of reasons.
Korn is in your heart. Yeah.
Korn is always in my heart. It's a religious experience on some level. Anyway,
Yeah.
all right. So I appreciate the horns there, Joel.
Thank you for that.
All righty, let's get into this presentation that I hopefully have enough time for. So I'm actually going to be sharing some information today around the co-occurrence of mental health conditions in the IDD population, and why this population specifically is at higher risk of crisis. Factors that are related to that. We're going to look at that from a biopsychosocial perspective, because there's a lot of factors that contribute to crisis for this population and for other populations, but specifically we're going to look at the IDD population. So in lieu of Mental Health Month, Babs has brought me here to talk about mental health from our perspective and the model consistent with the model that we utilize for 10 START. So just to give you a little bit of context here. So the co-occurrence of mental health conditions in the IDD population is pretty high. 30 to 50% of people with IDD have a co-occurring mental health disorder. This is twice the amount of the neurotypical population, or the population without a disability. So it is a higher likelihood, twice as high. But despite that very clear research all across the board that says they are more likely to have a mental health condition, it's not recognized. There's a lot of reasons for that. I've listed some of them here, but I do want to say, you know, there is a tendency to, for their disability to be overshadowed, to overshadow the mental health conditions. It's called diagnostic overshadowing when it happens, when they assume that the symptoms of mental health are attributed back to their disability, or that it is behavioral in nature because they have an IDD diagnosis. We hear it, we see it all the time. What happens, unfortunately, when people do not get properly diagnosed, their mental health conditions do not get treated, which, as you can imagine, causes people's symptoms to increase, potential decompensation to happen, leads to very negative outcomes, law enforcement involvement, you know, emergency service involvement, crisis, which is what we're going to focus on today, psychiatric hospitalizations. There are, you know, a slew of things that have to be done really to build the education and the understanding around this population that they can have, and are more likely to have mental health disorders. They can experience the full range of mental health disorders that you or I can. More prominent in this population is mental health disorders related to trauma, depression, and anxiety. Those tend to be the higher likelihood, but there are other barriers related to disabilities that cause those diagnoses to be difficult sometimes. There are differences that people have in their ability to communicate and describe their mood or their symptoms. Sometimes that can be impacted by their cognitive ability as well. And they definitely may present atypical symptoms, which often lead to incorrect diagnosing. There is an entire diagnostic manual specifically for the ID population for that reason, which is plugged here shamelessly and in the references. The DMID2 is a guidebook for diagnosing co-occurring disorders in persons with IDD, and has modified DSM diagnostic criteria and guidance for how to do mental health assessments with this population. So there is help and resources out there to help with this fact. But not everybody knows about those resources, so I always make sure I plug it when I'm talking about this. But there's a lot of barriers to treatment for mental health conditions as well for this population. So many people may discount, because they have a disability, their ability to accomplish treatment goals. They may expect too little from them. They may think that they can't participate in treatment, which is wholly false. And that they can assume that this is, you know, the symptoms are typical for the person because of an ID diagnosis, which is also horribly inaccurate. I think it's important to think about this from the perspective of challenging behaviors are not a criteria or a feature of an intellectual disability, even though they're more prone to those challenges, but there are reasons for that. And it should not overshadow the need for diagnosing of mental health conditions or treatment. So that's my short diatribe on that. I could spend a whole lot of time there, but I don't have a lot of time, so I'm going to move on.
While you were doing that, though, I discovered the reactions button, so I just started reacting.
Okay, congratulations.
I loved it. Yes, thank you so much.
So I want to talk a little bit, because I'm going to be talking about factors that increase risk for crisis for this population. But first, I want to make sure I'm going to be talking about vulnerabilities, because those are some of the things that increase risk. I want to make sure that people have a really good understanding of what a vulnerability is before I start throwing that word around. So I included a definition for you. So this is something that is almost always present for the person, and it impacts the likelihood that they may have difficulties or challenges. We all have vulnerabilities. This is not an ID specific word or term. So this can be things like health problems, exposure to trauma, having a disability can be a vulnerability, having a psychiatric diagnosis can be a vulnerability. It's something that's kind of an underlying thing that is always present, and is usually a combination of a lot of different factors that lead it to become a vulnerability, that the person experiences a higher risk of crisis. I want to make sure that you understand the difference between a vulnerability and a trigger. So a vulnerability is something that is always there, always present, and impacting that person all the time. A trigger is a stressor or something that's added to a situation that impacts, how the person responds and impacts directly that vulnerability. So a trigger is a stressor, and I want to be clear that when I'm talking about vulnerabilities, I'm talking about things that are always present and are usually a combination of different factors that lead it to become a vulnerability. So, with that in mind, I'm going to step through a few different topics that are the factors that increase vulnerability and risk of crisis specific to this population. So for the people with IDD, we think about biological, psychological, and social, or biopsychosocial, to save us some words, vulnerabilities, and how those factors may impact a person's daily life and impact their risk for crisis. So that's where we're going to start. I think it is really important to talk about, generally, there's almost never just one reason. There's almost never one cause of someone's challenges. It's usually especially when they have co-occurring mental health, it's usually complex and it's usually a combination of factors. There's a reason that these circles overlap all over the place. And depending on the specific individual, they can have multiple and some in all of these areas. And so that's where we come up with the biopsychosocial. These are all factors that contribute to someone's mental wellness or their mental health in general. So there are a lot of things listed here as examples, and I've got a whole nother slide of examples that are more common with this IDD population. But I do want to talk about, when you see symptoms of mental health or you see behavioral challenges, those can be related to a number of factors. The underlying cause, that vulnerability, can come from a lot of places. So it could be that, if we look at biological, they got a medical condition. And this could be anything from something small like an ear infection all the way to a more chronic medical illness, right? So UTIs, urinary tract infections, diabetes, seizure disorders, those are all medical conditions that can impact the person's daily life and therefore impact their mental wellness, especially if they're not able to describe pain, discomfort, how it's impacting them. That is going to present in a different way if they're not able to do that and to get the treatment or the relief that they need. That can lead to challenges with their behavior. It can also lead to mental health conditions and a lot of other things related to crisis. There's also factors related to their environment or their lived experience. You can see that kind of in the social circle here. That can impact them on a regular basis. We talk about all the time that a lot of times the IDD population gets fairly isolated. They don't have a lot of natural supports. Most of the people in their lives are paid supports. Sometimes they get separated from family. So those kinds of experiences can definitely impact mental wellness as it would for any of us, right? And those challenges can also arise from past experiences such as trauma. We know, and we're going to talk about that one too, but we know that they are at a higher risk for trauma, at a higher frequency and prevalence of adverse childhood experiences in addition to trauma. So those obviously impact someone's mental wellness, and that impacts their mental wellness for a long period of time. Medications, we just had a whole smarticle on it, right? Medications can play a major role in someone's mental wellness, good or bad. Sometimes polypharmacy happens where they're on too many psychotropic medications, not the right medications. Side effects of medications are huge at impacting, symptoms and everybody, people's day-to-day functioning. Just all sorts of things that can contribute here. The next slide that I have is really just kind of a list to get you thinking about in that biopsychosocial framework, things that can be common, especially for this population. So if you look across the bottom on the biological side, gastrointestinal issues, right? GERD, reflux, constipation, which is not only, you know, from a potential medical cause, but also from side effects of medication, right? So they all kind of interweave and interplay here. Um, we talked about seizures, dental, that one's huge. Dental issues, especially for those who have, you know, struggle with sensory issues. Maybe they don't care for the process of how it feels to have your teeth cleaned, whether at a dentist or at home. A lot of those types of challenges, if not properly supported, lead to lack of dental care, which lead to infections. Untreated infections could cause a whole host of biological issues and pain, and even psychosis if it goes on too long. So just thinking about it from that aspect. On the psychological side, we know that they have a higher likelihood of mental health disorders already. Oftentimes, because of the lack of treatment, the lack of proper support, there could be a lack of coping skills, a lack of resources related to that. All of those things impact their resiliency when it comes to being able to handle the challenges of mental health symptoms present. You know, communication around that, you know, communication differences is huge. We're going to talk about executive functioning and how that impairs a person as well in their day to day. And then getting into social, we talked about loneliness and isolation already, lack of natural supports, trauma. Um, Trauma doesn't go doesn't go away. That impacts someone for the rest of their life. History of being rejected, bullied, marginalized. Those are all things that contribute to vulnerabilities that put a person more at risk for crisis. Um, so lots of examples, lots of complications, lots of complexity in this. And often people have multiple factors in the IDD population across the board here. So you get most people know and recognize a behavioral challenge, right? Something like physical aggression, that is the thing that is very forefront. That is the most concerning thing, or self-harm. But it's not the underlying cause, right? We're not looking at where this is coming from. It's coming from the person being overwhelmed by what's being asked of them. Maybe they need help. Maybe they have difficulty expressing their emotions or their stress. Maybe they have anxiety related to a recent change or a loss. We know that these people, especially in supported living, are constant changes in staff, constant changes in what, you know, minimal relationships that they do have is constantly changing. Grief gets ignored in this population like you would not believe, and that impacts them just like it does you or I.
In
Sometimes
fact, we
they have
protect people
challenges.
against grief a lot of times. We try to protect them from grief.
Yeah,
And it creates a stunted situation where
yeah.
the person never really grieves
Yeah,
properly.
we end up creating complicated grief and don't allow them to process that loss or get them treatment related to that. Overstimulating environments is another one that can lead to, you know, behavioral expressions of a problem. Um, Responding to trauma triggers, having health issues like we've talked about. So there's a lot of things that lead to those challenging behaviors that people tend to get locked into, but we have to look at what's under it. Or
Yeah.
we
You
won't
know,
resolve anything, and we won't be able to help the person move to a more stabilized place.
that's right. I don't know how many times we've treated a traumatic experience as psychosis
Yeah,
and wondered why we didn't get good results from that.
yeah,
And the other thing, traumatic experience is listed as a social factor, which it is, but it also becomes a biological factor for many
yep,
people because it changes the way their brain functions.
yeah,
By the way, I'm
yeah,
just throwing this in. I had an 86 sleep score last night, which I'm very proud of. But the other thing, you brought up an example yesterday of someone because you talked about a post-ictal response that this person was having
hmm,
and the impact of that. Now, I think so many times we miss these medical conditions that may contribute to what we're seeing
definitely.
as far as symptoms go. Just could you describe that scenario just a little bit?
Yeah, so with START, you know, we do a comprehensive assessment. We look at all the biological, psychological, and social factors. We had a case of severe self-injury that we were working with. And everything in our gut told us there was something medical going on, no matter how many times, doctors had said, we checked, we didn't find anything. There were just a lot of indications that it was a medical symptom that we were seeing. We knew there was a history of seizures. The state that the person was in after what looked like a seizure, more like a focal seizure, was very obvious that there was something off. So we pushed and we got to the right neurologist. And we did find out that that person was experiencing postictal psychosis, which is a state that comes after the experience of a seizure that can very much mimic psychosis and very extreme aggression or self-injury as a result. So discovering that this is where this came from and shifting that perspective of caregivers to understand, this isn't aggression without a reason, right? That there is something happening biologically here, making sure that that epilepsy was treated effectively and having that kind of seizure protocol and knowing that this happens after seizures for this person makes a really big difference in how people respond to that. So those types of discoveries and assessments are so crucial to really getting a more effective treatment in place. So stepping through, because we are going to get more into trauma. We have some of the things you talked about, Bruce, are in my slides. Another factor that increases vulnerability and risk for crisis for individuals, and this was listed in the biopsychosocial examples too, is executive functioning. So couple of things about executive functioning. So people with developmental disabilities of any cause, there are a lot of studies that show that this is a very prevalent, executive functioning deficits are very prevalent in developmental disabilities. It's a set of mental processes that help connect past experience with present action. That's not the part I want you to take away from this. It's the frontal lobe of your brain is where executive functioning lives. It is more sensitive to stress than any other part of your brain, okay? So just your executive functioning section of your brain in general, mild amounts of stress cause executive functioning to shut down. So we all experience that. That can happen in the neurotypical population and the disability population, right? So if you think about a time where you've been really scared, maybe your ability to communicate is impacted, maybe your ability to move is impacted, especially if you're of the freeze as opposed to the fight variety. So this happens to everyone. Executive functioning shuts down. With people with developmental disabilities, they already have a deficit in this part of their brain development, executive functioning deficit, that causes them to have an impaired ability to do the processes that this part of your brain does. So if you take a population that has the deficit already and then put mild stress on it, it causes even more problems, right? That's the gist of what I want to tell you about executive functioning. So what does that look like? Big surprise, this is going to look a lot like challenging behaviors, right? So they're going to have difficulty with impulse control because that's part of your executive functioning. The executive functioning part of your brain does a lot of things that are very important to daily functioning. So impulse control is impacted. Emotional control. They may, and I don't like the word overreact because who's up to deciding if it's an overreaction? I don't know, but they have a difficult time, even though somebody else may see it as a very small stressor, not that big of a deal. For them, when their executive functioning shuts down, their emotional control shuts down, and it becomes a situation where they have severe emotional dysregulation, which is also another deficit that they have we're going to talk about. Their ability to adapt. So if you think about someone in crisis who's had a stressor or a trigger added, right? Their ability to adapt, to move past that, to de-escalate themselves, all of those things are impacted. Their ability to see the consequences of what they're doing on themselves or others is impacted by executive functioning. Their ability to initiate, to move, to do the next thing, to do the thing people are asking them. This can come into play If you think about all of those situations where there's been a mental health crisis with law enforcement involved, law enforcement is obviously going to be directing someone to do something. If their executive functioning shuts down, not only are they not hearing it, but they can't physically do it. So thinking about that when someone's in crisis, especially in our population where they already have this as a deficit, you add stress to it, it shuts it down even further. We're literally putting expectations on them that they can't physically do. And I think that that piece is really important, as far as, what crisis looks like and how they are impacted when they are in crisis. Super important. So yeah, it's significant issues.
Yeah, Michelle, I was
Can
just
come
thinking
from
about,
this.
because you were talking about how executive functioning problems affect everyone. The most common situation that I face executive functioning problems is when something goes wrong with the computer when I'm doing a presentation. That's like, I cannot focus on trying to fix that thing while also trying to do this presentation. It's just a huge stressor. And it just illustrates what a lot of people that we work with are probably dealing with on a daily basis, which is
Yep.
typical requests that are often made of them.
Yeah. Yeah. Especially if that typical request to us causes stress, right? You just
Oh
you
yeah,
just threw the match in the
absolutely.
gas tank on their brain's ability to process. So important thing to know. Moving into, I know I'm on limited time here. So sensory differences is another area that can increase vulnerability and risk for crisis. So there are 8 sensory systems. If you don't know that, most of us are familiar with 5 of them. So your normal touch, taste, smell, hearing, vision. But there are other sensory areas. So proprioceptive, that relates to your muscle and joint movement. The vestibular relates to your body and orientation in space. And interoceptive is your internal senses for how you feel hunger, thirst, and pain. So sensory differences can be either the way your brain processes the sensory input. So it can be an underreaction or an overreaction to sensory input. It can include things that lead to food aversions. It can lead to, how you use your body, how you move. There are a lot of impacts that sensory differences can have. Sensory processing disorders obviously can impact a person in multiple ways. So I just wanted to share some examples of how sensory differences in terms of being over responsive or under responsive may impact someone, especially as it relates to crisis. So let's look at the under responsive, right? Maybe they have a high threshold for pain. You see this kind of under responsive in those who have pretty significant self-injury, right? The over responsive, it's like in the autism community, for example, when they have sensory processing disorder, things like lights, things like sounds, things like quick movements can all be kind of overload the brain, right? That causes a stressor, then also throws out your executive functioning, shuts down, right? So you can go into crisis if someone's not there to support you, or they have a way out of that situation to avoid it, or they have some kind of whether it's headphones or sunglasses or something to kind of help mitigate the sensory input that's coming from that environment. So that overstimulation can lead to crisis. So there's a lot of different, safety concerns that can happen when it comes to sensory differences. One of the things that you'll often see is if somebody is overstimulated and they don't have a way out, right? They can't get away from whatever that stimulus is that's causing distress. That's where you see aggression. That's where you see someone leaving and running away, potentially putting themselves into an unsafe situation. So thinking about it from that perspective, there's a lot of different things that sensory differences can impact for people. And this is one of those areas that can lead to problems, at work, at school, with relationships. It can lead to depression. They're often very aware that they struggle, and it makes it hard for them to go out and to participate in regular things that they really have a desire to do. It can cause a lot of emotional dysregulation. It can cause isolation. and just underachievement in general, if they get pulled out of environments constantly because, it's seen as disruptive, then they don't get that same level of, learning and engagement and participation in just daily life. So there's a lot of impacts that this can have on multiple levels. All right, communication. This is a big one. This one's pretty significant. Differences in communication can come from a lot of different places. So it can be related to their cognitive ability. There are neurological and genetic syndromes that can lead to either, inability or differences in how someone communicates. Obviously, executive functioning deficits limit your communication when stress is poured on that part of the brain. Stress or trauma can, if you've ever heard of, things like mutism, or people who've had significant trauma and they're unable to really communicate or speak afterwards for a period of time, there are mental health symptoms that can lead to differences or loss of communication. So there are differences for this population, both on the expressive or how they communicate with others and receptive, how they understand and process others communicating with them. Very big deal, especially if you go back to where we talked about at the beginning, mental health models, medical models, they all rely on a person's ability to report symptoms. That's how things are diagnosed. If you have a difference in your ability to do that or your ability to communicate that effectively, it leads to people not getting diagnosed and treated effectively. It also leads to people thinking that they can't participate in the supports and services and treatments that they need. This is a really big deal. I mean, if you can't express your emotions, your needs, your discomfort, you get subjected to a lot of situations that are very distressing and even traumatizing, and can often be overlooked. We've all heard that kind of behavior is communication terminology. But for someone who doesn't have a good, effective way to communicate, it will absolutely lead to, if nobody's picking up on the signs and cues and knows them well enough to know this is a problem, they seem unhappy, like, let's figure this out. If they don't have that, it's going to turn into those challenges of, aggression and leaving and running. They're going to have to figure out a way to communicate. I don't like this. I'm under stress. I need something, right? It's going to come out somewhere. And it really can kind of overlay across all of biopsychosocial areas if there's differences in communication, and finding the right supports for helping someone to communicate effectively is huge, and impacts them in so many areas. It's just really significant. Trauma. Checking my time. We've talked a little bit about trauma already, but just to give you a little bit of a definition of trauma. So this is intense and overwhelming experience that involves serious loss, threat, or harm to a person's physical and or emotional well-being. A lot of people hear the word trauma and they think immediately of abuse, right? Or neglect, some of those very obvious trauma, but trauma can be a lot of different things. And a lot of different, varieties of trauma out there and exist. Trauma can happen at any time in a person's life. Sometimes there's a single traumatic event, and sometimes it goes on for years. For a lot of our population, a lot of the people we work with, they've had traumatizing experience for years. Trauma overwhelms the person's coping resources. So just to give, some examples of what other trauma, what trauma can look like: serious medical illness or disease, disabling conditions, loss of function, invasive or distressing procedures, being involved in or witnessing horrific events. That can be natural disasters, that can be terrorism, that can be pandemics. We're all familiar with that one. Witnessing death, witnessing the abuse of others or substance use in others. Things like, the food insufficiencies, being homeless, being bullied, loss of caregivers, divorce, domestic violence, whether you're experiencing it or observing it, anything related to drug addiction, parents being incarcerated, violence. So there's just, there's a million different forms of trauma. And we shouldn't limit ourselves to those big obvious traumas, because there's a lot more that this population experiences, especially when they have an inability to report some of their lived experiences and those traumatic events. It's just a really high likelihood with this population. Just to give you an example, people with IDD are 6 to 7 times more likely to be sexually assaulted in their life. I mean, there's just a lot higher prevalence in the trauma experiences of this population. Safe to assume that almost everybody with an IDD diagnosis has experienced some form of trauma. There's research all over the map as far as being, 70% to 90% of people with ID have experienced some form of trauma. Those are just the people who can report it. So safer bet is to say most of them have, if not all. It's often missed. The symptoms and the signs of someone experiencing trauma are often mistaken for those behavioral challenges, right? Or even for psychiatric disorders. It's impacted by the level of ID. Obviously, that impacts their ability to report, to explain, to talk about symptoms. People with disabilities are 4 to 10 times more likely to be sexually abused, like I talked about, and that's the variation across research. There's, obviously some a range of the likelihood. They're more likely to experience negative events, adverse childhood experiences. Trauma is a lot of things. Complicated or traumatic grief is huge in this population. But being exposed to any of these traumas really kind of disrupts the development of self-regulating, whether it's your emotional regulation, whether it's your executive functioning. It impacts your brain. I really like this statement from the research that I have listed in the references. The impact of trauma is neurological, it's biological, it's psychological, and it's social. It impacts you on every level if you've experienced trauma. It impacts your brain development, it impacts your psychological processes. It disrupts your ability to kind of have those coping strategies and that self-regulation on multiple levels. Your brain responds differently, especially if you've had long experiences or extreme trauma. Not only do you have less executive functioning as a neurotypical individual when you've experienced trauma, but you've also got the IDD population who already has this deficit, and then you're adding to it with trauma. People can get in what they call a survival brain, right? So it's kind of thinking about it, the state of experiencing that trauma becomes a trait, right? It is a constant state of flight or flight. And I try to explain this to people the best way I can. Put yourself in that fear for your life situation where you are fight, flight, or freeze, and imagine living in that. That's what some people with trauma are experiencing. That's what people in our population, in the IDD population, are experiencing. And living in that constant state of fight or flight with your executive functioning kind of shut down leads to all of those things we've talked about: the impulsivity, the emotional dysregulation, small stressors leading to, very big reactions. You hear people talking about, they went from 0 to 60, and nothing seemed to happen before it, right? They have those really big emotions. That can be a result of trauma. That can be a result of being in that kind of survival brain mode. All of that, even if you're not in that, all of trauma experiences raise a person's risk for severe emotional distress, increases the likelihood of suicide. It increases, because it affects you physically too, your likelihood for physical illness, your likelihood to abuse substances to try to mitigate some of those symptoms and those feelings. And in just a host of other life difficulties. It can lead to misdiagnosis, things, especially in this population, reenacting trauma may end up looking like psychosis for some instead of getting a diagnosis related to that trauma and treatment related to that trauma. So it can cause that kind of chronic irritability, anxiety, taking into account, how their behavior impacts other people. It impacts their ability to be part of things. So there's multiple aspects that this impacts people on. And I know I'm out of time and I've only got one left and I'm going to be really quick because it's kind of stuff we've already touched on. So emotional regulation is another factor that leads to crisis. Your ability to modify and manage your emotional state. We've already talked about how trauma and executive functioning, all of those things impact this population. Same situation for emotional regulation. Recognizing an emotion as a cognitive ability. So if you have a disability in a cognitive area, it becomes more challenging to do that. It becomes more challenging to recognize, talk about, and manage the emotion. And they require executive functioning too. So it's all kind of tied in related when it comes to emotional dysregulation. These are some of the things that you can see. If somebody has emotional dysregulation, so that reactive aggression, that irritability, anxiety being kind of present a lot of the time, quick changing moods, impulsivity, big reactions, right? So my wrap up is now that I've built this huge case for why people are at risk for crisis in the IDD population. Step one is you've got to identify these vulnerabilities. You've got to look at all of these factors. You have to look at the cause. You've got to figure out what the cause is in order to be able to treat the right thing, in order to be able to help stabilize the person. And then you have to put supports in place for things that we know are their vulnerabilities and make sure that we're addressing those. You have to, Ted Lasso says, be curious, not judgmental. You have to be curious to get to these causes. You have to ask the questions and push past we've already looked at this, and really kind of rely on professionals to really kind of get in and assess these things and advocate for it and share history and records and concerns. This is a big part of what 10 Start does. So if you know somebody who needs this, we will come help you and get all of those services and supports in place, and start addressing this. So ending with a quote, of course, beneath every behavior is a feeling, and beneath every feeling is a need. And when we meet that need, rather than focus on the behavior, we begin to deal with the cause and not the symptom. So that's it. That's my spiel. I will stop there. I don't know that we have time for questions, but.
Yeah, we don't have time for questions, but I do thank you, Michelle, for giving me the opportunity to use the rabbit emoji there to tell you to hurry up. But nonetheless, that was great. I appreciate you so much. This is such rich information, such important information, I think, for everybody out there to be utilizing on a daily basis. So thank you so much for coming on and presenting this. Thank you to Krishana for the Smarticle. And thank you to our audience for being here. Please be here again next week for the Clinical Consultation Network. Of course, we do it every week at 12:30, and we hope you can join us. See you then.